Excellent. Good afternoon. Mount Sinai, can you hear us?
Yes, good afternoon.
How are you?
Very good, very good.
This is Cindy. We have Roxana. We have a whole group of female panelists here. We're ready and anxious to see the amazing work that's being done with your hands.
Thank you. And I would like to thank CRT, especially Dr. Waxman, and actually his wife had sent us a beautiful painting which already was highlighted earlier, for giving this opportunity and first time that all women being involved in doing this kind of interventional cases. So if we can show the slides. So this is a 82-year-old female patient who presented actually to an outside hospital with a non-QAMI in January 2018. She had a cardiac cath there which had shown that she had left main as well as 3 vessel disease, had a syntax of 38 with normal LV function. While she was there, she also had a small CVA, completely recovered. CT scan at that time showed that she had an aortic arch ulcer with pseudoaneurysm. So heart team discussion at that time declined that this patient is a suitable candidate for a coronary artery bypass surgery because of the recent CVA and presence of atheroma in the aortic arch as well as the ulcer. So she was referred here for a high-risk PCI. So she did undergo right coronary artery rota plus DS done. She has a prior history of hyperlipidemia, vascular path with the AAA repair, and bare metal stent to the LAD in 1998. You can see her medication. She has been on the clopidogrel, and we can show the angiogram right now. This is her LV function. She had a normal EDP with normal LV function. The right coronary artery, 3 stents were done, which looks normal.
Beautiful.
And here we are on the left side. So she does have a distal left main disease, which is about 60-70%, and I would say bifurcation with the Medina classification 111. Ostial LAD would be about moderate, 50-60% disease. The significant disease actually is in the circumflex, which is about 80% or so. And today we are for the PCI of bifurcation distal left main. So if we can open up to the panel, how would we proceed? Yes.
So 1 stent versus 2 stent. Do you do IFR or FFR to determine hemodynamic significance of the LAD? At least from this view, I don't really know how significant the LAD is. Certainly the circ looks very tight.
Yeah. Very interesting question. That even I think in the Excel trial, whenever there was a distal left main with involving other disease in the distal vessel, they would prefer IVUS rather than fractional flow reserve. So we actually did intravascular ultrasound both from distal left main to LAD as well as from distal left main to circ. If we can show the IVUS, please. So what we got from, like you had mentioned, Cindy, that ostial circ was about, ostial LAD was about 6.1, and distal left main just about closer to ostial LAD was probably 8, but significant disease was from distal left main going to ostial circ. So show the measurement of the ostial.
So a lot of calcium there. Did you
6.1, right?
Qualified for?
And then this is the run.
CSI?
This is the run from the ostial circ coming back to the, just show where the measurements are. Yeah, this is exactly where we were. So this is the ostial circ about 4.2, but then the distal left main was 5.6. Another interesting point also is when we were trying to do this, if you can see that.
So before you show us the other side, Anu, it's wonderful to see an all-female team, yourself as the lead, your 2 fellows who you're training, women, and the entire female staff. This really is historic. It really is incredible. I would never imagine that this would ever happen, and we really have Ron Waxman to thank for, especially seeing an entire incredible number of women who are great interventionalists. I would like to know, Cindy, you see that here Anu used, Dr. Kinney used a, and I'm making sure we call each other doctor, because that's another thing we should do, guys, call each other doctor on the panel. Anyway, so Dr. Kinney just basically showed us that use of intravascular imaging is actually crucial. How many of you are performing, Mirvad is here, or so many great interventionalists are actually performing, when you have a distal left main, would you ever proceed without imaging? I think that's one of the big questions here. Right, I know, Cindy, you are a big proponent of it, but...
Yeah, absolutely. I think I like to use a lot of IFR, actually, to determine hemodynamic significance, particularly if there's absence of disease downstream. I think it's very helpful. But then it's always, the IVUS, of course, is very helpful because it tells you the size of the left main, and it's quite large, isn't it? Yeah.
Yes.
Exactly. I was going to say the same, being trained by Dr. Grimes. You can imagine that I was all my left mains. So definitely that's the next step that I would have taken, do a good IVUS of the distal left main in both LAD and circumflex.
Yeah, it'll help you strategize as well. So if angiographically you see the ostium, well, now the ostium of the circumflex is obviously diseased, even angiographically, but occasionally you don't. And you will be surprised from the IVUS that it is. And so you may change your strategy accordingly. So something like this, I would consider a DK crush simply because the LAD is a much bigger vessel than the circumflex.
But the left main itself, as you pull more proximally, it's quite large. It's like 6 or so, right? So what stent would you think about using in this situation? And where would the crush go? The tightest lesion is in the circ, although the circ invariably tends to restenose osteocirc lesions. Aliade?
Yes.
I think, honestly, IVUS, when I use IVUS, is just to see the distribution of the plaque, but I don't use IVUS to decide for intervention or not. To intervene or not, what I use usually is functional assessment, and this is what it is normally advised. Here you have not significant by IVUS, both LAD and circumflex, which is not because it's more than 4.0 that theoretically is the cutoff. Indeed, there is a significance by IVUS as far as it can matter of 5.63 if you use the old criteria from JASTI of 5.9. So in this case, without a functional assessment, I would go provisional, honestly. I would go provisional left main toward the LAD because the only significance by IVUS, it should be demonstrated by functional assessment, is left main itself. And the disease in the circumflex is really short. And then you can always go from provisional to stent.
Right.
If you don't like the results on the circumflex.
So while we've been talking, looks like we've got some wires going down. So Dr. Kinney, tell us what your strategy is.
So I just want to show something else that I think we can show the slide that we had made, myself along with the fellows, what's called as a bifurcate app. They can start showing some slides about the bifurcate app, which will be actually presented. Surbi, the fellow who is next to me, herself, as well as Samit Bateja, the two fellows, key fellows responsible in making this happen, and it will be presented during the ACC this Sunday. So if you see that, I think since we know it is a very technically challenging bifurcation lesion, we made this app, which is a very educative tool as well as will be interactive. If you are using it, you can download it free from the Google Play or from an app store. So there, if you go to left main, since angiographically we decided it was 111 lesion, we described that 111 lesion to be taken care, you have 3 options, which
Can you
were
just put
either
the app on the main screen, and we don't need to see your faces or the angiogram, so we could just see what you're showing us.
Okay, so we'll keep going next. So if you go to the next slide, which will be the left main, go to the next slide. Yeah. So you see that, you click on the left main, go to the left main now, and when you're going on the left main, it will tell you this is Medina 111, and in Medina 111, patient is stable patient, because if the patient is unstable, we said the only way of taking care of that lesion would be by doing a SKS. You just do 2 stents and come out. But in a stable patient, we give you a treatment option of either mini crush, DK crush, or culotte, whichever the operator will be comfortable with, and you pick one particular step, and then it will tell you what the steps are. So in this particular case, the question comes now is initially we did think that LAD disease was significant, but now with IVUS, once we know the LAD disease is not significant, do we still go for the double stent strategy, or knowing that this lady who has history of CVA and long-term DAPT may be an issue with her, that do we go with a single stent strategy from left main to circ, provisional stent strategy, and change our stenting strategy here? What do you think?
Well, we can ask our panel that. Personally, I really enjoy the one stent strategy in general. It's unusual to put that stent into the circumflex, but I think it's going to be very easy to rewire the LAD and rescue it if there's a problem. So that sounds reasonable to me.
No, I would go left main to LAD, honestly, because it's not significant, both the ostium of the circumflex. I mean, by IVUS, we should see by FFR, but I think by FFR it's going to be not significant.
You think that the circ is not significant, but do you think the left main, do you think the LAD is significant?
No, it's only the distal left main significant.
Yeah.
But you don't have, I mean, you have to do distal left main toward the main branch, which is LAD.
Right.
I mean, by IVUS it is not. By FFR, if it's by IVUS not, most probably is not significant because it's a very short lead of the circumflex, and then you can always go from 1 to 2.
I have to say I do a lot of IFR and FFR, and when you go into the beyond the proximal circumflex, you can have a reverse FFR. I don't know whether you've noticed that, and the reason is that your guiding catheter is at a certain plane, and the circumflex is very posterior, so the pressure that you're reading distally is much higher than what it should be, and so you can have a false negative IFR, FFR in the circ, unless you pull that wire back to the very proximal portion. So what is your strategy, Dr. Kinney?
Okay, so here we did a cutting balloon, Wolverine, the new Boston Scientific cutting balloon. We had a 275 Wolverine. We went up to 8 atmosphere to the circ and distal left main, and this is where we are, that it looks like it's well expanded. So even on the IVUS, what we saw was only 1 quadrant of calcium. So we know this kind of lesion would definitely respond to atherectomy. That's no indication to do any atherectomy here. So with that, it looks very good. So here we are, that having the discussion that do we go 2 stent strategy or we say 1 stent strategy and come out. I'm okay for either of that.
So you chose the cutting balloon because there was, what, 180-degree arc of calcium?
No, like only 1 quadrant, like 60-degree arc of calcium.
Oh, okay. And then could you describe the difference between the new cutting balloon and the old cutting balloon?
Okay, so the new Wolverine as well as the previous flextome. The previous flextome, what used to have at the base, there was a nice big plate, but the cutting part of the cutting balloon was the same. So the base plate was removed. So it is just the cutting balloon that is just attached onto the balloon. So it's very flexible, and the way of deliverability of this balloon is very good. You see how it actually went into the circumflex very easily. So that's the only difference, but the performance of the balloon is excellent.
And is this a 7 French guide or 6 French?
This is a 7 French guide, because our decision based on our angiogram was that we will do a 2 stent strategy, that we will go mini crush, which would be 3/12 stent into the circ, and then we take a 3/5 into the left main, and when we post dilate we will go 4/0, because the diameter of the left main you are getting is like 4.2.
Okay, so you chose a 7 French because you're thinking about a dedicated 2 stent strategy.
Yes.
With regard to any comments from the panel?
Yeah, I mean, I completely agree with her. You will need a 2-stent strategy if you just look at the IVUS numbers that she presented to us. I mean, if we look at the circumflex cutoff of 5, LAD of 6, and the left main of 7, then if you're going to optimize the left main stent and do hot, you will jail these the ostia of a vessel that's already diseased by IVUS. And you will likely get away with it if you use this 2-stent strategy, though. Upstart.
Yeah, I can say you, Dr. Kinney commented on the simultaneous kissing technique, and personally I don't like that. I've had cases where the double barrel part is just way too long, longer than you think it's going to be, and then you're setting yourself up for late stent thrombosis. But importantly, I have, even though I try to train our fellows to deflate simultaneously, and Molly, I'm sure you've done this with me, you deflate simultaneously, and then when you do your IVUS, you see one of the stents is actually crushed. So you cannot deflate simultaneously and have a perfect double barrel, particularly when it's going around a bend like the circumflex.
So it looks like we have several different ideas on the panel. So,
right.
So Mirvat is thinking a dual stent, probably a mini crush. The rest of us are sort of thinking about, especially given that the patient has a history of a CVA, we're worried about prolonged dual antiplatelet regimen, that a single stent would be maybe a better option. But then the question is a single stent into which one of those branches? LAD is thinking definitely into the LAD, your main vessel. No. If you are going to do the distal left main, both of them looked good, but some of us thought maybe it should be into the circumflex. It looks like she's already used the cutting balloon. So I guess that's how much there is. There are so many different ideas. So what do you want to do? It looks like you're already moving ahead, Anu. Dr. Kinney.
So the thing was same. I think it was looked like half and half, that single stent versus two stent strategy. So if you see here, I took another Wolverine to the distal left main to LAD, and getting Wolverine across the distal left main was not that easy either. So we have just did a cutting balloon. We still have time if you think that we can come out with a single stent strategy. But I think the way this is behaving, that even if I think that we go a single stent strategy from left main to circ, that would be a 3-0, and then we have to post dilate with a 4-0 pot into the left main would not be an ideal situation that we may then have compromise of the LAD. I would think do a dedicated 2-stent strategy with a mini crush and be done with it.
I think we need to consider why we're doing this intervention. If we are trying to achieve full revascularization in a patient with ischemic cardiomyopathy, or is it just for symptoms, or was there any evidence of ischemia in which territory was worse than the other? Just trying to find an excuse to stay with a single stent strategy, to one, keep it simpler, and second, to not have to worry about the long-term dual antiplatelet therapy.
Yeah, it's actually looking pretty good just with your cutting balloon, surprisingly enough. So we don't have coronary drug-eluting balloons, but I know in Europe there's been several studies looking at the use of drug-eluting balloons for side branches. Can you comment on that, Dr. Keffel?
Yeah, I mean, there is not enough data, I have to say. Clearly, if you balloon, you have to stent for me. I mean, if you use a cutting balloon on the LAD, you must implant a stent. This is a prognostic vessel already stented. That's why I would stent first left main to the LAD and then see the result on the circumflex, and eventually, if I'm not fine with that, I can even be guided by an FFR or IVUS, whatever she thinks is most.
Well, there was a study, I think the ISAR group did a study comparing use of drug-eluting balloon on its own versus following a cutting balloon, and they actually suggested that the penetration of the drug after a cutting balloon was actually superior, and they had a little bit less restenosis after that.
Right? Yeah, but here we're talking about left main.
Oh, right. You have to place a stent somewhere. I'm talking about if you wanted to do a one-stent strategy, would you ever treat the side branch?
For me, on the circumflex. Never on the LAD only.
Okay. Well, the circumflex, I mentioned before, there's a lot of restenosis with stenting, whether it's from fractured stents, or maybe there's accordion of the stent, or maybe we're opening up on the the part that's convex, and perhaps we're opening it up too much, and there's plaque prolapse. For whatever reason, there's a lot of restenosis in the circumflex. So, Dr. Kinney, describe what's happening now.
So we are going for 2-stent or single stent? We haven't decided.
Well, what do you think? I mean, I think some of us are feeling that now that you've put in, have you committed yourself to 2 stents because you used cutting balloons? Some people here on the panel feel that way. I personally don't.
I don't at all.
I feel that I think you should stent across the circumflex into the LAD, the main vessel, and take a look and see how things go after your stent. And you can always put in another stent into the circ if you need to. I know you're very capable of doing that. That's what I would do.
That would be my goal too.
Yeah, I think I would do that too, and I like the takeoff of the circ is conducive to putting in a T-stent as a bailout strategy.
But see, the significant disease was left main to circ. You see that? And
okay, audience. Let's do a poll of the audience. So actually, audience and the panel. Who would go with the one stent strategy? Okay, how many would go for a two stent strategy?
Wow, half and half.
Yeah, one stent's maybe a little bit more than the two stent, but it's not that far off, really. Unfortunately, we don't have a lot of evidence that two stent is better. The only thing we have is the DK Crush trial, which showed it was better than provisional stenting, but for some unusual reason, they had a pretty high complication rate in their provisional stenting group.
I mean, there is now a randomized clinical trial called EBC Main, which is randomizing 1 versus 2 stent strategy by European Bifurcation Club. And the strategy in case of 2 stent, which is recommended, is or DK Crush or culotte.
They're recommending a crush or what?
No, DK Crush. If you want to crush, is DK Crush or culotte versus provisional. But provisional, the European Bifurcation Club way, which means pot, stent, cross. I mean, you have to pot before crossing and then a final report.
Yeah, well, you can still pot after the culotte or the DK Crush. Okay, so what's the plan here? We
the final call now. Are we? If we are going to go to two stent strategy, we are going to do mini crush versus a single stent. It has to go from the left main to circ. I think we will go
Maybe
for
it's better the chemical crush.
Roxana, what do you think? Dr. Mehran?
Well, no, I said what I thought is that you should go into the LAD and see how it goes. If you are going to do a single stent, I would go into the main artery, which supplies a big chunk of this vessel, this patient's heart, and then if you need to put a second stent, you can go ahead. But I think, you're the person, you're the operator, you're there, you know what you're doing, you perform so many cases, you should do what you believe is best for this patient.
So in that situation, we are ready for mini crush. We'll just do that. I'll take a 3-5-16 to the left main to LAD, and we have a 3-0-12 that will go to the circ only. There's a 3-0-12? Okay, that will go there. 3-0-12?
So this patient is elderly and she had a AAA repair. Would anybody put in an Impella if you're going to do a 2-stent strategy?
No, if LVF is normal, she already opened the RCA.
Right. Okay, anybody? Okay, so everybody would do it unprotected.
I would just have the balloon pump, at least something in the room, but not to begin with, so just have it in the room. And
also she has that pseudoaneurysm on the aorta, no? So
it's a right dominant system, and the EF is normal. If EF was low and it was a left dominant system, it would be a different story.
Right, so complex bifurcations if the EF was low.
Okay,
right?
As the token surgeon on the panel, how bad was her CVA? Because I'm not quite sure why we discounted surgery so quickly in this.
I don't know either, but she's 82, and she had, but she had aortic disease. They said that her ascending aorta had ulcers.
No, they said at the arch, but I mean, that arch is also, every wire change is also getting bumped with it.
Yeah,
so,
that's true.
And you could do this without touching the aorta.
Yeah, we would probably do
hybrid
robotic Lima to LAD and stent the circ if you thought the circ was.
That's true. I mean, we do have the hybrid trial going on. We
are actually part of the hybrid trial, and Dr. Kinney has enrolled many of these patients in the hybrid study. Actually, she's continues to enroll patients there, and I think it sounds like we might have had to send them to you as the surgeon, Jen.
Yeah, because I have to say that those in my center, no way that this would have been ever accepted by a surgeon, honestly.
Really?
No. They would turn down, I mean, for sure, 100%.
So we went with a 3-0-12.
I mean, most of the time we don't actually even get to know about the arch, and so we just kind of mush on. and I'm telling you, if this is the kind of left main with these complicated things, we would be very gentle with the aorta, but it's, I think everybody in our group would have done this without really much thought.
So
But the point is that now, after the revascularized the RCA, because as far as I understood for acute coronary syndrome, now she has only left main, distal left main. So Finta score low.
So the stent
it
is a little
the same
bit
indication.
oversized or something. So just the edge of the stent and beyond there, and the mid-circ looks a little funny now. I can't really tell what's going on.
I agree. I think it was seen right before she put up the stent. So I think
So it's
perhaps
just
giving some nitroglycerin before and then seeing if there's really any plaque shift or not.
Okay, done.
So we have IVUS on the table, so we can easily take a look at that.
So I'll have to recross and kiss now.
So you pulled the guide back. Was that because it was damping or something, or was it sucking
it's just
into?
that whenever you're pulling, otherwise there'll be a bad suction of the guide into the, that's why I just pulled it out. Get me, 275. Compliant.
Yeah, we have 3 minutes according to my phone. So, so if we can get a picture here, and then maybe a strategy. You're going to recross into the circ.
We'll take a nice picture now because we have the wire out. Ready?
So this would be a good time to pause.
Give some
do
nitro
proximal
before.
optimization before
we're
she
giving
recrosses.
nitro. Here.
Yeah, so
Blood pressure
sometimes
is
when
so
you
far so good. Actually, going back to the question of using Impella, there has been a recent FDA indication saying that patients who have been deemed high risk by surgeons, even if the LV is normal and you think it's a complex PCI, you can use Impella.
Yeah, you don't really need to have a really poor EF anymore if it's ultra complex, and it was just recently approved for use of pericardium cardiomyopathy and severe LV dysfunction due to SCAD.
I think the distal edge looks okay, sir.
Yeah,
Yeah.
angiographically it looks good.
So now recrossing will be the same that we will go, though the recommendation is that you got to use a non-compliant. I am going to use compliant balloon to get into the circ.
You know, and this is where I've gotten into difficulty sometimes because you have the stent might not be fully opposed to the left main, and sometimes you're wiring behind the stent. So doing your pot up front would be helpful in that regard. But it's a very short segment.
Based on the European guidelines, the pot is a must. They always say first you do a pot before you kiss, and more they are recommending that you have to do pot and maybe serial kiss, or just do a pot rather than do a kissing balloon. Okay. So now what I did was I took the run through that was in the circ when we took it out along with the STS. I rewired the LED with the run through, and now the fielder wire that was in the LED is gone to the circ. Now taking a compliant balloon 275, though the stent was 30, and we go to the circ, and then we have a high pressure 35 going into the left main to LED.
Okay, I think our time is about up here. Anything else you want to tell
so you see that we are able to get the balloon across very well. And now we go from left main to, wait 1 minute.
And then you'll plan to do a final imaging and making sure, because just distal to that left main, to the circ stent, it looks like
we want to
there's
make
something
sure that
there.
it is well opposed, yes.
But you'll make sure it's well opposed, and you'll get complete full visualization of both sides before she leaves us. Before she leaves the patient off the table.
100%, and we know usually in this kind of situation that you want a stronger dual antiplatelet therapy with the Brillianta. In her case, because of the history of CVA and elderly and risk of a bleed, we did check a PRU on Plavix, and it was just 106. Okay.
So the PRU is low?
Go up with the circ.
I guess I share the concern about putting a potent agent on someone who's had a CVA, even though Brilinta does not have a negative indication. You still, even with the elderly CVA patient, in a non-STEMI, she should do better unless there's some bleeding issue. So with I would love, this is why the Twilight study would help us so much, to have this kind of a study of withdrawing aspirin instead of having to withdraw the or change or downgrade.
Okay, I think that we have exceeded our time. I want to thank you, Dr. Kinney, for this amazing case, and it looks absolutely beautiful.
We're just going to come out and take a final picture. Just
final
1
picture,
second,
okay.
and then that's good. Yeah. Okay, down. So just to tell you, my people who are around with me is Surbhi. She's an interventional fellow. Then I have Asma, who is the second interventional fellow. So we always have at least 1 to 2, sometimes even 3 women fellows. They are the ones who have helped me in this case. I have the nurse who is Sarah, and I have Vicky. Vicky actually is a veteran here. She's the one who taught me when I was a fellow. And then I have Yulia, who has helped me with the imaging, and Karina, who was a tech, who has helped this entire case. So it was a all-women case with a woman patient who was also very excited to be part of this. So this is just amazing. A final picture.
Looking good. Okay, very good. Thank you. And thanks to the panelists.